Tonight it gives us a great deal of pleasure to welcome Dr. Curtis Westersund from Calgary. He is a dentist, obviously graduated from the University of Alberta in 1979 and operates a general practice in Calgary, focused on precision jaw orthopedic therapy. He holds a mastership within the International College of Cranio-Mandibular Orthopedics. Those of us in the field will recognize ICCMO. He is the current vice president of that organization. He has a Disclusion Time Reduction certification and trains dentists for Tek-Scan, which is a digital occlusion sensor provider. His practice treats patients with chronic head, neck, and jaw pain associated with cranio-mandibular and postural strain, as well as sleep disturbances associated with obstructive sleep apnea and upper airway resistance syndrome. You'll find in his CV a number of his publications. He's written in Cranio, the research in computerized occlusal analysis in dental medicine, as well as the AADSM, the American Academy of Dental Sleep Medicine. Tonight, we are so privileged and happy to have Dr. Westersund speak to us on the topic of dental sleep therapy and occlusion. Welcome to our webinar, Dr. Westersund.
David, thank you very much. Bianca, thank you very much. Everybody out there, I see a few names that I know. Hi, Barry, how are you? Thank you very much for the kind words. You kind of saved me from boring people with my second slide. So I'll start this right now and we'll kind of get into it. Is that okay?
Absolutely.
Okay. So we're talking about sleep and occlusion. And of course, I'm aware that typically occlusion during the nighttime would be some clenching, perhaps some bruxism, and those can all be issues, but I'm not going to focus on that. What we're going to focus on is more how occlusion during the day can affect your therapy at night, and how that occlusion during the day may actually affect the success that you have with your sleep patients. And first, number one, the fact that so many more dentists are getting into sleep dentistry, kudos to all of you. It makes a huge difference as to how we're able to provide health to so many people. It's poorly recognized by quite a few of the medical profession, by our own profession. The more of you that are doing this, kudos to all of you. Hold on a second here. I'm going to back up. As Dave was saying, I have some of these initials. I ran out of the alphabet, so we'll just leave it at that. Basically, I'm a general dentist. I've been around for 43 years. My practice is about 90% chronic pain and sleep. When you're a dentist of 43 years, you tend to have a lot of patients from when you were younger, and fortunately, a lot of them stuck with me. And so I do have a little bit of general dentistry in my practice, but we're mostly dealing with motor vehicle accident patients, patients that come in with numerous jaw issue problems, TMJ problems, head and neck issues, and we're taking those patients and we're looking at those patients. You see a picture of me there holding the T-scan, and obviously this was back before COVID because I don't have a mask on and I don't have a gown and a little cap on my head. So it's an old photograph of maybe 2 years. Yeah, nowadays, I'm sure it's all interesting in Ontario as it is in Calgary, but we're basically doing the same type of dentistry day in and day out. Now, I don't know the sort of the skill set of everybody or the experience of everybody that's there. I'm sure some of you are very well experienced. Some maybe are a little bit newer. I'm going to talk try and talk generally about things. What we know about adult sleep disturbance issues is that there is a number of sort of signs and symptoms that we get with having all of these adult sleep disturbances. You know, stroke, stress, hypertension, weight gain. We see all those things. I see a lot of motor vehicle accident patients, and a lot of them have trouble with sleeping after that. But not only that, we have a lot of patients that have motor vehicle accidents or collisions because they're tired. You know, cardiac, lung, brain fog, all these things I'll see that's coming up in patients during my week. Now, one of the things we quite often don't think about is we don't think about jaw pain and how that is affecting. And so what I want to focus today is how does our treatment of adult sleep disturbance issues affect things like jaw pain? Now, dental malocclusions are very common. The patients that I see, I would say there's probably about greater than 90% of the population has a malocclusion. Now, understand that a malocclusion does not equal pain. So a person can have a malocclusion and not have any pain with it. They're accommodating it. They're able to alter and change their body in such a way that that pain isn't showing up. We see the signs of it. And basically, when I talk about malocclusion, I'm talking about a strain within the body. So the body has a strain that they must accommodate, whether it's muscle tightness, whether it's loss of function, breaking down of teeth, wearing of teeth, etc. So we have this strain, and the strain is accommodated by the body until it's not. And that's when a lot of symptoms show up. So you'll have a sign of this strain being there, but then the symptom of the strain will come when it's no longer accommodated. Now, obstructive sleep apnea, of course, that's less common, probably about 20%. I think in the United States was the last one I saw was 20 million people were apneic while they slept. Obviously, there's a lot of people that aren't diagnosed, unfortunately, but that's a rough estimation. But still, 20% is a lot of people. Now, when you consider these patients that have a sleep apnea, how many of them also have a malocclusion? And it's probably quite common, because malocclusions are common. Obviously, then a lot of these sleep apnea patients are going to have a malocclusion. And then how are you going to deal with that? So are these two problems related? And do these problems affect the outcome of each other? Is a sleep patient going to have more of a problem because they have this TMD issue or malocclusion issue? And is the malocclusion or TMD patient going to have more of a problem because they have a sleep disturbance? So what affects sleep and what gets affected by sleep becomes the issue. So I think we can all agree that treatment of obstructive sleep apnea is pretty important for health therapy. It's underdiagnosed, it's under-observed, but it's a very important thing in health therapy. I think we can agree that the medical golden standard is the CPAP. And the CPAP works really, really well. But obviously, the CPAP has a problem with tolerance and compliance. So if you're not wearing the CPAP, is there going to be a problem? And I think we all probably are aware of this and know this. And of course, what's the alternative? The alternative is the mandibular repositioning device. We want to bring the jaw forward to where that airway issue is being improved. We know if we bring the jaw too far forward, though, that muscles, mylohyoid and other types of muscles will create a negative effect. So you can actually make the sleep or the sleep disturbance issue worse if you bring the jaw too far forward. So you have to bring it, has to be able to come forward into that position. You have to reposition it. And also, we also know that some patients have pain with their mandibular repositioning device. So they go and say, hey, doc, we put this in, we give them this to try and open up their airway in the middle of the night. But what happens is that they will, sorry, my computer, there. It'll be like, doc, the appliance you gave me makes my jaw hurt in the morning. I can't wear that appliance. Or now I wore that appliance for a little bit, but now I have this other problem. And you're going, wow, they didn't teach me about sleep apnea in school because I don't think there's any real education. I have a son in third year dentistry, and he's not had any education in sleep apnea. So you have to pick up from lectures and from people like myself and through the various associations on sleep apnea, but they never really get into what makes somebody not be able to tolerate or what happens when somebody's jaw hurts in the morning. And we all know that basically you wear the MRD at night, and then in the morning there's jaw pain, muscle pain, TMJ pain. And so this MRD therapy is not tolerated. So what's happening? Well, on the left, there's the jaw before you went to bed. Then in the middle, there's a jaw during the night. And in the right side, there's a jaw in the morning. That kind of makes sense. You have your teeth biting together, you know, for 2/3 of the day, and for 1/3 of the day at night there, you're wearing this MRD. And it's bringing your jaw down and forward. It's opening you up. It's repositioning the jaw. Now, how do you do that? Well, you do that with muscles. And obviously the sleep appliance is adding some bulk there, but that jaw joint has to come forward for that to happen. There has to be changes in the soft capsular tissue around the jaw joint. And in the morning, there seems to be a problem of going back to where you were the day before. I think this is fairly understandable. So what do we do about it? How do we solve this? And I think you'll probably answer, well, Curtis, what we do to solve it is we have the jaw for bed, the jaw at night, and then in the morning, we have this thing called a repositioner. Works great. And for a lot of our patients, that's going to solve it. I could end the lecture right here. This is all we have to do, is just wear that repositioner. But what is that repositioner doing? Well, it's helping you relax some strained muscles. It's helping to reposture the TMJ back into the fossa and back into where it was before you wore the MRD. And it's reacquainting the neural responses from your teeth to your pons, lower part of your brain. And so all of this is happening with this repositioner. But then I got to ask, what is the repositioner not doing? Well, the repositioner is not balancing an inherent muscle problem. And if you look at EMGs in the photo there, we see that under rest, those are the EMGs when you close lightly into the habitual bite or light CO, we see the muscles start to become more active. In this case, it was the temporalis muscles becoming much more active because to bite together, they had to bring the jaw back and up, and they had to recompress that TMJ that had been uncompressed during the night with the sleep appliance. So the repositioner isn't changing that. The repositioner is not restoring proper TMJ function. It's not putting you back to where the condyle is sitting back and up into the fossa. It's not repositioning that, and it's not creating an ideal or a better function within that jaw joint. And it's also not balancing neural input. And for those of you that know what T-Scan looks like, T-Scan is in a digital sensor, something that patients bite on. And that digital sensor can tell us which teeth are hitting first and which teeth are hitting most. and which teeth are hitting the longest during biting or during function movement from side to side. So what we've got here is we've got a positioner that's dealing with most of our problems, but we're not looking at those problems during the day that we may want to be addressing separately or with the sleep issue. I mean, if you take a look at this, what's the prognosis of morning pain with a TMJ that looks like this? Well, it's kind of, it might be there. It's kind of nebulous as to whether or not that's going to be dysfunctional jaw joint. But when you take a look at this one, you say, oh, yeah, okay, that's going to be a very functional or dysfunctional jaw joint. We have very little of the disc left. We have calcification of the disc, ossification of the condyle, and things don't look all that healthy. So we know that the second picture is going to, the second CBCT is going to show a patient that's going to have more problems. Is the first one going to? Don't know. Second one going to? Probably. Well, what does that mean? Well, you know, if you have a daytime occlusion that is a deep overbite or very deep overbite, you can create a retruded and strained mandibular position. To bring your jaw back and up is to bring the condyle back and up. And that's what creates most of the clicks and pops and the grinding that we see in patients. So this becomes an issue. Now, it's because I run a referral practice, I get a lot of dentists that send me TMD patients because they just don't want to deal with it. It's not something they have fun at. So, but when you're looking at a sleep appliance, should you be also considering this TMD dysfunction and possibly what you're going to do with it? So how do you consolidate daytime function with nighttime function? Now, if you look at this, what we're going to see is daytime versus MRD. And we can see we've got on the left-hand screen, we've got an abfraction or gum recession. We've got a deep overbite where you can't see the lower anteriors. And we've got an anterior action of the mandible coming forward. And it comes forward so much and so often during the day that it actually wears down the teeth. And we're going to make this MRD. So how are we going to consolidate these two things? I did a study with Zephyr with their Matrix Plus system, which we use in the office, so they could get an FDA approval for Matrix down in the States. And what we found is there's between 5 to 10% of the patients had trouble wearing their appliance. Now, a lot of patients, I thought, oh, you're really going to have an issue. Turned out to have no issue at all. And there were some that I said, oh, I think you're going to be okay with this, and turned out to have trouble. So it was difficult to predict what these patients were going to get. But is there a way that we can predict this before they buy something? Well, is there a solution that be effective? Now, if you're using the Zephyr, which is I'm not sure how many are familiar with the Matrix Plus product, but it offers a diagnostic baseline study, plus it does something called a theragnostic study and therapy diagnosis. And it says, does this diagnosis actually solve the OSA problem? And are the patients able to tolerate that? And in these 100+ patients that we did this work on, we found that there was still a number of the patients that could not wear the appliances full time because of their daytime occlusion. So can the management now of the daytime occlusion affect our MRD therapy? Now, there's no studies that say if you do my type of treatment that's going to make them have a better result from wearing an appliance. The studies aren't there for that, but what I've seen clinically is that when I deal with the occlusion, I have very many fewer patients that have trouble with the MRD therapy that they're going ahead with. So what are options for MRD pain during the morning? What would you do during the morning to get rid of it? Well, you could have them wear CPAP, right? You could just say, look, you can't wear my appliance. Here's CPAP. It looks something like this. I maybe have exaggerated. I'm not sure. And you can go to that. But a lot of patients are coming from CPAP. They don't want to go back to CPAP. And so you can say, suck it up. This is part of dealing with your sleep issue. And your sleep issue, if it's not dealt with, may end you. It may end your life. It may shorten your life dramatically. It may cause things, with pregnancy, fertility, with all these other issues that I described at the start. And if there's kind of a change in occlusion where they feel that their bite has altered because they can't bite on their back teeth, oh well, so sad, too bad. Or you can improve their daytime function. And I think that's what I'm trying to get at here, is that when we're hit these obstacles, we can actually improve their daytime function. So if your patient presents with a deep overbite, retruded mandible, some TMJ dysfunction, some clicks, some compression of the condyle into the fossa as you palpate through the ear, or maybe they've got a constricted airway or a forward head posture. These patients you're going to look at and you're going to say, okay, yes, you do have a nighttime airway problem, but you have also some major daytime problems. And those major daytime problems are things that we want to discuss with you because they may actually affect how well we can treat you at night without using something like a CPAP. And that becomes very valuable. So we're solving it for daytime appliance. So how do we do that? Well, we're basically looking at the structural strains and potential symptoms that a patient may have. If we look at nighttime strains, we would look at, soft tissue constriction, collapsed oropharyngeal space, and physiologic stress, neural stress. And we would see the dental symptoms would be the OSA, the upper airway restrictive syndrome, the clenching, and the bruxism. So that's what we'd look like if we were looking at night. So what do we look at during the day? Well, we can still have airway constriction during the day. It's not dealt with the same way, but it's still as much of a problem. I have 2 rules for my patients. Every single patient in my office has to qualify for these 2 rules or they're not my patient. First rule is that their head has to be attached to their neck, which is attached to a torso, and there's some assortment of limbs, usually 4. I'm not particular. Second rule, in other words, you can't ship your head in a box and say, hello, Mrs. Jones, hello. Can't do that. The second rule is that they have to be breathers both during the day and during the night. I accept no non-breathers. If you're going to stop breathing for the weekend, we're going to have to send you a cancellation of treatment letter. And I know that sounds kind of silly, but it brings home to patients that they're not just a head or a throat. They're an actual human being that has symptoms and stress and issues that go from teeth to toes. So when we look at daytime strain, we're looking at jaw muscle pain, we're looking at headaches, migraine, TMJ strain and something we call postural strain, which you'd say, look, and I'm not Curtis, I'm not a chiropractor, I don't care about that, but it's actually something that affects our treatment and can affect us when we're providing it. What are our phenotypes for patients of OSA? Well, we have the constricted pharyngeal airway space, right? We may take a CBCT and we see that we have a very constricted airway space. You know, we got class 4 malapathies, we got class 3 tonsillar pillars. It doesn't look like there's an airway back there. A lot of patients don't have a typical sleep apnea. What they have is a pharyngeal collapse. I have that. I don't have sleep apnea, but I have upper airway constricted syndrome. Kind of a nebulous diagnosis. I don't know of anywhere where it's really being, where sleep physicians are saying, I can definitely diagnose that and I can definitely treat that. About the only treatment would be a CPAP. And we're going to have some neuromuscular connection, CO2 sensors, some insomnia, some restless leg syndrome. And we're going to have short narrow-maxilla retruded mandible, and we maybe have an increase in body mass. All those things are phenotypes of patients with OSA. Of course, we all know that we can get a slim young female coming in and she could have UARS and have this pharyngeal collapse and have just as much of a problem as some big old fat guy like myself and having this issue. So body mass, take with a grain of salt. What are the phenotypes of malocclusion? Well, cross bites, scalping of the tongue, an anterior bite where they touch tip to tip and they create a keyway pattern. We could have a deep overbite. We could have what we call a bicuspid drop off. In other words, the canine, the 4-3 and the 3-3, as they go back onto the first bicuspids, it drops down. And what's happened is that the anterior 6 teeth have erupted because of the issue that is dealing with the short mandible or the retruded mandible and the short maxilla. Limited opening. What do you do if a patient has limited opening? TMJ click, TMJ compression, postural issues, other TMJ issues. We could go into a whole several-hour talk about TMJ issues and how that affects various patients and what that looks like. And of course, a lot of patients with malocclusion that I see during the day have these breathing issues, OSA and UARS. So those two phenotypes for night and for the day are slightly different. Our daytime patients, a lot of our phenotypes for both show a short, narrow maxilla and or mandible. It's not uncommon for people that we're treating for sleep issues. It's not uncommon for people that are treating with TMD issues. Then we start to understand that there's an epigenetic reason why that mandible shows up as being short and narrow, and that's got to do with tongue position. And then we start to deal with tongue issues, tongue ties, etc. And what are we thinking about? Well, if we think about that tongue, it has to live in the bony box formed by that jaw size. If this happens to be your jaw, that there's a box, there's a container formed by those teeth where the tongue has to live. Often it can't live there. So what does that container do? It pushes the tongue back, it closes off the airway. And that's why we see daytime airway issues that relate into a lot of the symptoms that we have. We see the tongue going side to side. We see the bicuspid drop off in this case. We see the lips and the cheeks pushing the teeth in. We see the teeth haven't erupted properly. These are all signs and symptoms when we look at every single day, we may not even be aware of, but these are the patients that are going to have trouble with our dental sleep appliance. And so we want to be able to look at those patients to diagnose that ahead of time. Now, muscles work across the joint, correct? So the muscle attachments for the TMJ condyles, there's the pharyngeal tubercle, the superior pharyngeal muscle, pteromandibular raphe, buccinator, orbicularis oris, and then insidious inferior, and how all that sort of forms that tendons around these tendons around these muscles around these bones. And the airways obviously at the back around the writing of pharyngeal tubercle. That's where our airway sits. And therefore, the mandible and the pharynx and the hyoid, their position directly affects airway patency. Now you say, okay, Curtis, at night you're laying down, everybody's asleep, and their jaw just drops open. But again, we're using that MRD to move forward. And if we have that retruded mandible, if we have that short, narrow maxilla, we're going to have to compensate even more. And that becomes our issue with compliance then. So what do? I provide a combo therapy. So this is one therapy that fixes an important problem of sleep, and another therapy that's looking at the structural problem that can lead to debilitating pain. Now, patients I come in, they're seeking out help because of TMD issues. Pain is a common thing, but pain isn't always the common thing. Quite often it's a loss of function, and the loss of function that we're treating during the day is very important and helps also their problem of sleep. Now, what are you going to do? Well, you could make an orthotic for a patient and ask him to wear it all day. But the patient's not going to wear an NTI all day. And the patient probably doesn't want to wear an acrylic orthotic all day. It's maybe doesn't look nice. It maybe doesn't feel great. We're altering potentially tongue posture. We're doing a whole bunch of things that maybe patients don't want. And I'm sure we've all made, maybe not all of us, but many of us have made an NTI. I'm sure we've all made orthotics, but we expect them to be worn at night, right? We don't expect them to be worn during the day. So what are options? Well, we could do something like this. The top shows the occlusion, their natural occlusion. The bottom shows their occlusion with an appliance in their mouth. And that's an acetyl resin orthotic. It's comfortable to wear. It's able to bring their TMJ function into a better position. And we're able to use something like a T-scan to balance it. It's something that can take pain or patients that are in pain immediately and help relieve that pain. Sometimes that pain is relieved quickly. Sometimes that pain is relieved over a long period of time. Let's talk about that a little bit. There's basically 3 types of conditions that we're dealing with that are making these pain. One is a reflexive condition. And that is if you go to a dentist, you get a filling done and the filling is high just a little bit. As these teeth contact, say the filling's high on the right side, as these teeth contact and begin to hit in the right, what are you going to do? You're going to reflexively move your mandible to the left. And if the filling isn't that high and the patient can accommodate that, life's good. Everything's fine. You can accommodate it. But sometimes patients can't accommodate it. quite often what I'll see is I'll see patients saying, I've got a high spot in the left, and it's actually on the right. And we use the T-scan to figure that out, and we adjust the filling, the appropriate restoration that we have to make everything balanced. The second type of pain is called an active pain. If you were to paint your ceiling tomorrow, and you're painting your ceiling, your shoulder would be sore and your back would be sore. And for a few days, you'd have all that muscle strain and problems from that active use of these muscle groups. So people that chew gum a lot, people that are trying to keep their jaw active because they don't want to bite on their habitual teeth, their habitual bite, I should say. Those are people that tend to be having more active pain. And then there's another group, which is called habitual accommodation. And that habitual accommodation, and quite often habitual pain, is something that's been happening over a long period of time. And so you have pain because the jaw development from by the time you were 10, your jaw is finished developing, and it didn't develop positively. There is a negative aspect to that development. And that negative aspect you've tried to accommodate all of your lifetime, but then as you get older, whatever that age may be, you begin to have signs and symptoms. So what we're able to do with an orthotic like this is we're able to not only deal with the reflexive accommodation, the active accommodation, but we're also with the habitual accommodation and the growth factor of where the jaw wanted to be and where it had to be. And we try and make the jaw where it wants to be. And we use this orthotic. I use Orem Dental Lab in Calgary, and it's called a natural fit orthotic. And this orthotic is something that you can wear all the time. I have one in my mouth right now. I have an orthotic on my bottom teeth. I wear it because if I don't, I get migraines, neck aches, TMJ problems, etc. Now I also wear an MRD at night. So I have this combo therapy where I have something to stabilize myself during the day and something to stabilize myself at night and help my airway. And these appliances can be worn so often, are so comfortable to wear that you can even, the photos above are of this patient, and she's wearing it at her wedding. This has helped her so much that she's able to function. She had planned a wedding. This is obviously pre-COVID, and she had planned a wedding. She had pushed it off because of her chronic pain or chronic headaches, all the other issues she was having. And so this orthotic was something that solved all those issues. And you're saying, okay, Curtis, but we're talking about sleep. So yes, we're talking about the combo. We're talking about taking care of their sleep issues, which you do, and then taking care of their daytime issues, which you may not do. And by combining these, we don't have patients that start to have these problems. And I'll talk about that in a sec. So if a patient has functional strain, why should we ignore it? Just because they accommodate functional strain, are we not mouth doctors? Should we just say, I don't want to talk about it? Because one, I don't really understand it. Two, I don't think the patient will buy it and they just want to buy what insurance covers. And three, the patient just wants their teeth cleaned. Is that our limitations? I don't think it is. I think if we see a patient with functional strain, we should at least be able to diagnose it. We may not want to treat it, and that's why I get referrals, but we should be at least able to see it, talk to the patient about it, help them diagnose it. We can provide this 24-hour support for our patients. our compliance is no longer a problem. So today's Wednesday. I've had 2 patients this week where we've made them a combo, where they would not be able to wear their MRD and go into their habitual bite during the day and not have problems. And because of that, we're now able to, now understand, I get everybody's nightmare. They have a TMD patient that's driving them up the wall. Go see Curtis. Perfect. Love it. No problem. But that's because we have lots of tools in the box so we can provide these types of things. And so as dentists, we should be looking at how can we help with this functional strain. So our daytime and nighttime airway patency is supported. Can I just take a few moments to talk about daytime airway patency? The body accommodates daytime airway patency. The most common one we see is a forward head posture. Their head's coming forward. And I work a lot with upper cervical chiropractors and know a lot about upper cervical alignment. And we see that these patients are bringing their head forward because it actually, in these cases, increases the size of that oral pharynx during the day. And since we have to breathe during the day and during the night, remember, that's one of my rules. We want, the patients are automatically bringing their head forward to open up that airway to allow the air to flow in without turbulence, to be able to get that deep breath. And then what the patients do is they'll tip their head back up. And we see that all the time. And I'm gonna show you some examples of that. But airway patency is not just a nighttime issue. Airway patency at night is a different issue, but daytime airway patency, we don't really think about because everybody just does it. Most important thing is your next breath, and your body will do anything to get your next breath, including putting you into pain. It'll put you into a painful situation to get that next breath. And so daytime airway patency is supported. And we're also at the same time, we're helping to either maintain or improve TMJ capsular health and TMJ bony health, because we're allowing that compressed TMJ that's sitting too far back and up to come forward as the jaw comes down and forward during the day and during the night. So the first step comes down to diagnosing the occlusal problem in your initial exam. And this is where I see a lot of people that come to me and say, well, why has nobody talked to me about this? Why did nobody mention this deep overbite? Why did the hygienist tell me that my gum recession and my abfractions was toothbrush abrasion, which we all know it's not toothbrush abrasion. It's vectored force on teeth because of function. And so this isn't getting diagnosed. And occlusion isn't getting diagnosed properly. And in a lot of cases, except for you fine, wonderful people, the nighttime airway isn't getting diagnosed. So I feel that occlusion should be diagnosed in your initial exam. You can then talk to the patient. You can assess, if I'm going to make this patient an MRD, are they going to need a daytime orthotic? Because you want to be able to discuss that with the patient prior to treatment. Wouldn't it be a good idea to say, hey, you may have this problem, but I don't know yet, but you may have this problem, just so you know. I'm going to make you this great dental sleep appliance. It's wonderful. You're going to have the best sleep ever. But because it brings your jaw forward, your jaw may not want to go back. And if your jaw doesn't want to go back, then this may be something, doesn't happen often, but this may be something that we have to treat. And I just want you to be informed of that so that there's enough information to the patient about potential future treatments. Does that not make more sense? Isn't that seem like a better way? If you're a patient, wouldn't you like to know that there's some issues that are going to affect you that you may have to treat? It's going to make you look better. So can physiologic occlusion improve MRD effectiveness? There's no, as I said, there's no study that says relaxing these jaw muscles is going to make your UARS get better, or that your sleep apnea is going to get better. There's no medical evidence of that. But it may make your MRD more tolerable. And I've seen this with a lot of patients. Can improvement in daytime occlusion allow for larger MRD parameters? Okay, when we're looking at how far forward can you go with your jaw, how far back can you go with your jaw, what are these parameters? And then can they be improved because we actually treated a TMJ dysfunctional issue, an occlusal dysfunctional issue, a muscular and fascial dysfunctional issue during the day? And can that make our nighttime treatment effective? Does relaxing the oropharyngeal muscles improve OSA? Probably not. Again, I said no studies. Can you reduce or eliminate MRD morning pain with a daytime orthotic? Right from the start, I said you could try just putting something in their mouth that's soft, they could chew on for a little bit to allow the jaw to go back, or you could look at the bigger picture. Now, what we're going to do is some simple diagnosis issues. In the last few minutes here, we'll quickly go through these. There's a correlation. The correlation between airway and OSA is weak. So we know that you can take a cone beam CAT scan. These are cone beams of my patients, and we can see that there's airway issues. The one on the upper left, we see that a lot of black, upper airway constrictive syndrome. The one on the upper right, probably the same thing. One on the lower left, probably the same thing. The one on the lower right, I'm not sure if you're noticing, but there's a neck involved in there. And notice how that neck's going forward. We have a reverse curve of the neck, and we have a restriction of the airway. So, and we also have a deep overbite, the mandible sitting back on all four of these. We need to bring the jaw forward. So these are patients where this helps me diagnose TMD, but doesn't necessarily diagnose OSA. But daytime airway affects the structure, as I said. Here's where there's a coupled motion. We're not all just parts. We're not Lego blocks. So if we have a TMD problem, a potential airway problem, quite often we're also going to have a postural issue. And if we notice in these on the left, she's standing fairly straight, but her head's forward, and she bends her head back, her head bends back so she can see straight, because the eyes help give you balance. The middle one, we have this great curvature in her lower back, a hypolordosis of the thoracic and the lumbar vertebrae. And so her torso's forward, her head's forward, shoulders back, and her butt's back. And the one on the right, she's leaning forward. She's trying to get that party early. She just wants to get into the room first. And she's doing what we call the banana by bending backwards. She's making a big curvature of herself. All of these are TMD patients and airway patients and postural patients. We have to deal with the whole thing. Simple little test. If you want to see whether or not your patient's going to have problems, put your fingers in their ears. You know them by now. With a glove, take your little finger, put it into their ears, pad forward, have them open and close. Do you feel a click? Do you feel a compression or a closing onto the pad of the fingers? That's going to tell you whether or not you're going to have a potential problem. You can do it to yourselves too. Open and close with your fingers in your ears. Do you hear a click? Do you feel a compression? If the answer is yes, you've got maybe a couple of issues we should talk about. How many fingers? We all know this. Can you get in 2 fingers? You can get in 3 fingers or 4 or just 1. How is your MRD going to work with somebody that has a limited opening? Probably not very well. Obviously, look at these crowded teeth, decayed teeth, everything. That's good. That's a TMD issue. That's also an airway issue. So you know that there's probably going to be both in those situations. And lastly, we all see this. Wear, severe wear. That's an airway issue during the day. That's probably an airway issue at night. And it's probably also a retruded mandible position that we got to deal with during the day. So we can choose to ignore it, or we can do something about it. That becomes your choice. Everything's a choice. I love choosing. You can choose to tell about it. You can choose not tell the patient about it, or choose not to tell the patient about it. Everything's great. We all know that force affects function. And in my case, the way I deal with it is I want biometric evidence. I don't want to be guessing. So I'm going to use things like a T-scan, right? Barry knows all about this, is how dentists assess a patient's bite. You can do it analog versus digital. If you don't know anything about T-scan, learn something about T-scan. There's a lot to know about it. It's way more accurate. You could be a Jedi Knight of articulating papers. You can be the Jedi Knight of articulating papers. I'll make you a bet, $100 each of you that want to bet me that you will not be able to pick the malocclusion and the dysfunction by simply using articulating paper. It's amazing how much digital is different. No real-time data versus real-time data. Before micro adjustment, after a micro adjustment. Simple things that you can do with a T-scan. Here we have somebody, this is the old T-scan handle. We're listening to her jaw muscles, her temporalis muscles, and then we're going in and we're adjusting teeth as we see fit. Your bite, you can change your bite. You can use something like a case 7. This is a case 7, and listen to EMGs, and you can adjust their bite and figure out where to do all that. There's other ways, lots of other ways. I use a case 7, use case 7 every day. My last patient today was a case 7. And this is how we use it. We have that bite material in there. There's a picture of me. God, I'm handsome, aren't I? Joking. And here's an orthotic we're putting in. Now this is orthotic is hybrid. It's a partial denture and an orthotic. And these are very, very stable. This patient's missing some molars, and we have these beautiful teeth that we set in there. And this is the product from that case 7. And now we're going to use the T-scan to actually balance that. So we can make that nice and balanced. If you don't know what a new chiropractor is, what an upper cervical chiropractor, this is the kind of work they do. They do a lot analyzing the body, analyzing the neck, and then their treatment is a non-event. Look at her face. She's not like, oh my God, you put all this pressure on it. You can barely feel this. This here is Dr. Jeff Schulten, and you can barely feel it's not a tickle. It's more like a vibration behind the ear. But what that does is amazing to helping your patients with these types of problems. Now understand, you don't go to bed and then just have perfect posture. You go to bed, if you have imperfect posture during the night or during the day, you have it at night too, which means that people may have to lay on their stomach. They have to be prone, supine, side to side, and that may actually dictate some of their sleep issues. And then of course we can use something like a biomechanical therapist. And what he does is he does massage, he does alignments. You can use a variety of different therapists that will help restore somebody's lower back, below the head and neck. Because we don't just start, or we just don't end at the neck. We have a whole body. And quite often that means you got to take care of it by stretching, by making motion. Motion is lotion. By doing these types of stretches can actually help TMD, can actually help that patient. Combo patients, we just did this one. She's missing lower teeth. And so what we did, yeah, I know they're kind of dark. She's going to actually get those done when she can afford to. But what we did is we made her an MRD and an orthotic. And you can see how it's supporting her daytime much more forward than where she was, while it's supporting her nighttime as well. So basically, she eventually wants to get her upper teeth done to match the orthotic. Perfect. Simple, do some 10 veneers and everything looks beautiful. So diagnose all occlusive problems, inform the patient of concerns before treating, and have effective tools. Buy some tools. You can eliminate patient frustration. You can improve the relationships. My advice is also find a collaborative team. Saying that I can do it all myself is dangerous for a healthcare provider. Saying that aloud is a dangerous thing because you can't do it all yourself. So find a team, upper cervical chiropractor, massage therapist, whatever. Last thing, we're going to end up on this. You can be a soldier, you can be a scout. The soldier's got one focus in their mind. A soldier is going to win that battle. It's that battle. I got to win. My sword's held high. I'm going forward. I'm going to beat that opponent. Or you can be a scout. And there's actually a very good TED talk on this. Julia Gallup, why you think you're right, even if you're wrong. Take a screenshot of that, everybody. Go look at that. It's a very good TED talk. And basically what it comes down to is that you see the patient in front of you that eyes the question. A scout's mindset is to think like a scout. Be inquisitive. Look at that patient. Be inquisitive is to, not that it's happening, but why is it happening? Not that I want to just inject Botox, but why should I need Botox? Could I do it without Botox? Keep an open mind. Look from different perspectives and try and understand the cause of everything. And I think we're right at an hour. And thank you very much. And I appreciate everything. That's my email address. And if you want to get in touch with me, you can. Remember that I'm in Alberta, so Mountain Standard Time, but I get up early. So anytime in the morning in Ontario is fine with me. Usually that's when I got lots of free time.